the difficulties and achieve a good outcome in treating such disorders. And I will talk myself on a topic of intracranial atherosclerosis, and the endovascular treatment is still a valid treatment in some situation or not. And I think Dr. Oskan, he is ready to join us now.
Or more options are not coming to the computer, so I'm trying to arrange it.
Mm-hmm.
The only thing is just came up is mute, and the other things, the sharing part, did not come yet, so I'm working on it.
I will try to make something.
Check the photo. I'm coming to other.
You can now check, and you will find the share screen on your.
Okay,
on your...
now it came.
Yes. Okay.
Now it came.
Yes, we are seeing
it came
you
now.
clearly.
Okay, it came now.
Okay.
Something did not come now. It's okay. Okay.
Yes.
I think you can see it now.
Yes. Okay.
Did it come up?
Yes, it's okay. You just yes. Now it's okay.
Okay. Okay. Now I'm gonna start now.
Yes, please.
Okay. Sorry for the delay. There was some technical problem that I couldn't manage initially. Now it's the Osama solved it as usual. Okay. Thanks for giving me the opportunity to talk about the topic about resistant thrombectomy. So, as we know that mechanical thrombectomy is beneficial comparing with IV thrombolysis alone. So the trials came up at 2015, and there is a great benefit from these trials. As we know, the number needed rate varies from 4 to 8, and it's a great benefit for all medical field. However, there are certain problems that we are facing because these trials actually exclude the majority of some of the patients, including sometimes tendon occlusion, sometimes a great tortuosity of and some patients with great anatomical difficulties. So we are still facing some problems when we are doing the mechanical thrombectomy. So I'm talking about the resistant thrombectomy and how to deal it with the current technology. This is the actually NASA trial. The Zaidat and the colleagues, all interventional neurology and other colleagues published it. It's the importance of first pass thrombectomy. Our actually aim in the endovascular acute stroke field is to achieve first pass thrombectomy, and we know that if we achieve first pass thrombectomy, the patient's outcome is better. And majority of the TK3 result is coming from the first pass thrombectomies. This is important. So if we achieve a good recanalization with the first pass thrombectomy, the chance of having good outcome is higher, the mortality rate is lower. So our aim is to achieve first pass thrombectomy in the first pass. However, this is not the issue sometimes. And in this trial, in NASA trial, maybe 20 or 30% of patients may achieve only first pass TK3 thrombectomy. So when we look at the definition of resistant thrombectomy, there are several papers, but I just get the 2 papers. And the majority of the trials actually accounted this. If you have more than 3 pass, then you have actually resistant thrombectomy. And the current trials like EMBOTREP, trial, ARISE trial, that the actually investigators use EMBOTREP trials, use, for example, more than 3 passes and accept 3 passes for the trials test. So if you have a more than 3 pass with the stent reaver or other devices, then the definition is resistant thrombectomy. When we look at the preset stent, it's coming from Germany, and clinical experience with the preset stent. There's a very nice result showing that if you have more than 3 passes with the stent reaver, then the chance of TK3 thrombectomy is very less. It's only 7%. And average procedure time for sure is higher if you have more than 3 pass. And if you look at the modified score of 0 to 2 or a good outcome, you have only 13% of patients may get a good outcome after 3 passes of stent reaver. So it means that the more you need passes, the less good outcome you have, and the less chance do you have TK3 thrombectomy. So this is important. So this is my algorithm for the causes of resistant thrombectomy. The first one is anatomical. If you have a very bad arc, very bad cervical loop, and the cavernous segment is tortuous and U-shape, and if you have a bad MCA IC angle, the chance of resistant thrombectomy is higher. And I'll show the studies about that. The second one is technical issues, using of balloon guiding catheters, stent size, retrieval technique, aspiration, and combination. And the thrombus etiology, for sure, occlusion site and the thrombus etiology is important. And if a complication due to endovascular treatment, then the chance of getting good outcome and the first pass is quite low. If you have a new territory embolization, then you have to go for another territory and do the stent again or aspiration again, and the chance of resistant thrombectomy is higher in these patients. The first one is anatomical situation. If you have a very bad carotid tortuosity, type 3 arc, and very elongated arc, the chance that you can get your catheter up into the internal carotid artery segment is quite difficult. And the chance that you are getting the clot out with the stent reaver system is quite lower. There is a current study that was published in World Neurosurgery 2019. They actually created a score, a bad score, bovine arc, aortic arch, and dolichoarteriopathy. Bovine arch absent or present is important. Aortic type, arc type is important. And ICA dolichoarteriopathy, it means that mild kinking, moderate or severe kinking, or tortuosity and coiling. You give 1 point for each. If you have a score of 2 or more, then the chance of getting reperfusion in a certain time is lower, the mortality rate is higher, and the chance of getting good recanalization is lower. So if the anatomy is not good, or if the anatomy is not actually good for the patient, and if you have bad anatomy, by the destiny, the chance of getting first pass thrombectomy is also lower. And what is the solution for that? If the aortic arc is very bad, and you can use the transradial cerebral technique, nowadays is a common technique, or you can use a transcervical access and acute ischemic stroke management if you have to. But it can solve the aortic problem, but it cannot solve for sure, the cavernous segment or internal carotid artery anatomical problems. You can have in this field, very severe kinking like this, or some kind of kinking, or you can have a coiling like that, a 360-degree turn in the ICA. Here is our patient with kind of kinking. And if you have kinking like that, very severe kinking or coiling, the chance of getting dissection during the procedure is higher. So you have to have some kind of stenting available if you have this kind of patients and have dissection. And this is a classification of procedural complexity in pipeline embolization. This is in the cavernous segment. Here is this U-shape and S-shape cavernous segment makes it difficult to engage microcatheters, distal access, and to engage the pipeline stent. So this is the study published in AGNR. That's the curved MCA and the influence of the vessel anatomy on recanalization results. If you have a kind of very severe angle between ICN and MCA, the chance of getting first pass recanalization is lower. So to summarize, the anatomical situation in the patient, both in the aortic arc, both in the internal carotid artery, in the anterior circulation, cavernous segment, and the MCA and ICA angle, sharp MCA and ICA angle, makes create some difficulties in getting first pass thrombectomy, so it may cause resistant thrombectomy. It's one of our patients, 54 years old, female, left hemispheric stroke. This is the occlusion in the inferior branch. It's the thrombus. There is the very severe tortuosity in cavernous segment, makes it difficult to engage. We tried first solitary platinum, couldn't achieve first pass recanalization. Thrombus is still here. And here is the stasis of in the cavernous segment in this kink because of these manipulations, the solitary platinum. We used balloon guiding catheter in this patient. He couldn't get first pass thrombectomy. And this is a combined technique. We used Solumbra technique for this, and this is the distal axis catheter. We had to use it, and we created a dissection, spasm and dissection, and then we had to stent the internal carotid artery. We achieved recanalization after 4 passes, caused the dissection, but the modified Rankin score of 3 after 1 month. So recommendation, we have to always perform a roadmap while passing the cervical king or coil to see how the anatomy is, and during the pass, we need to be gentle. It's difficult to pass the very severe kinking or coiling with balloon guiding catheters.
Buna nasıl karşılık verebileceğimi bilmiyorum.
And this is important to keep the guiding catheters or balloon guiding catheter below the segments. Guide wire needs to be always in G shape. A combination of distal axis catheter and stent may be used. Sometimes we have to use 6 French. We can use 6 French distal axis, but it's very difficult sometimes for in cervical kink or coil. We can we can use 44 or 4 or 5 French distal axis catheter in this time. And nimotipine can be administered, and also the other calcium channel blockers can be also administered in these cases. And sometimes we can give continuous nimotipine infusions during these cases in order to prevent severe spasm, and we have to be ready for the dissections also. So anatomical perspective is very important. And now the other issue is technical management and technical issues in the acute stroke management. These are important things that we can achieve first pass thrombectomies and prevent resistant thrombectomies in several times. There is the Raul Nogueira's paper, as we already know, the push and fluff techniques. We can use several techniques that we can achieve first pass thrombectomy and prevent resistant thrombectomy by these techniques in reusable stents. If we oppose these stents as far as we can, especially in the nitinol stents, then we can achieve more first pass thrombectomies and maybe prevent resistant thrombectomies. See, the opposition of the Trevo stent is better to the wall, because these are nitinol stents. We get the thrombus between the endothelium and the stent, so we have to oppose the stents very well to the vessel wall. This is important. Another technique is active push deployment to achieve better vessel wall interaction. Here we see the better wall interaction while pushing the deployment with the push the guide of the stent rather than unsheathing the microcatheter by itself. It may create much more better vessel wall interaction. So this is a recent paper. If we use longer stents, like instead of 40-30 or 40-20 solitary platinum. If we use 40-40, or instead of 420 trevo, instead we use 430 trevo, longer stents. The chance of getting first place thrombectomy is higher. If you use radio-opaque devices like solitary platinum or trevo, the chance of getting first place recanalization is higher. So this is important for the setting that we have. Here is the solitary platinum stent. In this stents, we can have much more rate of first pass thrombectomy, and we can actually prevent maybe resistant thrombectomies in these cases. So we can use other techniques such as aspiration and stent combined techniques with balloon guiding catheters or without balloon guiding catheters. It is the safe technique that we use combination of stent and distal access catheter. There are very few differences in this between these two techniques, but two techniques actually recommend retrieving the stent into the distal access partially, and when we squeeze the thrombus between the stent and the distal access catheter and retrieve the both components together. And if you use the distal access catheter system aspiration both with the stent, then it's always recommended to get the microcatheter out in order to enhance the area of aspiration, especially if you use 27 microcatheter, and it may block the majority of the lumen of the distal access catheter. So it's better to get out the microcatheter and retrieve the stent and the distal access catheter system under continuous aspiration. So if we have, if we actually perform the stenting and get more than 3 stent retrieval, what can we do? The first strategy can be switching this strategy for mechanical thrombectomy. For example, if you perform stent thrombectomy and you cannot recanalize the vessel, then you change it to aspiration. Or you start with aspiration. If you cannot recanalize the artery after 3 passes, we change the system and switch it to stent system. Is it beneficial? There are 2 papers coming from the South Korea colleagues and showing that if you change the system after 3 passes or 5 passes, change the strategy, thrombectomy switching to aspiration switching to thrombectomy, then the chance of getting better recanalization is higher and the better outcome is higher. So the first trick is, if you cannot recanalize the artery in acute stroke setting, you may change the system. You can switch it to stent, you can switch it to aspiration. This is the first thing. Is it any clue that we can just from the start, we can just predict what device we can use, aspiration versus stent retriever? There is a paper from that was published in Stroke 2018. If the thrombus is the regular here, the chance of getting actually benefit from aspiration is higher. If the thrombus is irregular like that, the getting benefit from the stent retriever is higher. So irregular thrombus, stent retriever is recommended. Regular thrombus is aspiration recommended, but it's not the actually 100% for sure, but it may give some clue to us to which strategy should we start is the first phase or initial phase. The third component is after anatomical evaluation, technical evaluation, and the thrombus structure for sure. That every thrombus is different, especially fibrin dominant thrombus or calcified thrombus is very resistant to thrombectomies or even aspiration. However, in the red blood clot dominant thrombus is much more unresistant, and the chance of getting first pass thrombectomy is higher. Here is the one patient with a calcified emboli, one of our patients. We had a great difficulty to recanalize. After first 5 pass, we achieved recanalization in this patient. It's a kind of tandem occlusion of the patient coming from the atherosclerotic carotid. The MCA is occluded also. We have to do 5 passes. Here is the thrombotic material. It's much more fibrin dominant and calcified. And there's a paper from Dobrowski and colleagues, a thrombectomy of calcified emboli. And if you have a calcified emboli and the Hansfeld unit is very high, the rate of recanalization is very low. It's almost 12%. The poor prognosis is higher, and intercerebral hemorrhage rate is quite higher. So the thrombus content or histology of thrombus is important. You have sometimes very rubbery, very hard clot that you cannot achieve recanalization in the first pass to the second pass or third pass. So there is a recent kind of novel geometric technology here in vitro model, geometrical difference of stance that you can achieve this recanalization in the heart clots. And this is one of our patients. Actually, we couldn't pass the thrombus occlusion with the guide wire. We tried several times, so we couldn't attempt for stent retriever technology. So we come across proximally with the distal axis catheters, the Sophia 5 French, and then we achieve recanalization with the aspiration only, and we get this kind of material. This is the after a mitral valve replacement, and after our cases, one case report just came out, a case of right middle cerebral artery tendinectomy. So this is chordotendinia. This is coming from the bypass, this chordotendinia structure. Sometimes the surgeons cut the chordotendinia during mitral valve replacement, and this is the material coming from there. So these are all different clots and different histology that makes very difficult thrombectomy. So you have to ready for all kind of technologies and all kind of system, like aspiration, thrombectomy, and both. This is one of our cases, 57 years old male, global aphasia, right hemiplegia, forced eye deviation during TEE examination, NIH-20. This is the ICA-C occlusion due to cardioembolic source. We navigated 9 French balloon guiding catheter and aspirated from there. Aspiration with balloon guiding catheter, and then we went 6 French distal axis catheter under balloon occlusion through the distal ICA, and then we achieved the recanalization in the ICA. However, the MCA is occluded. Here you see the anterior cerebral artery is opened. However, MCA is occluded. Then we go for combined system, both with solitary platinum and distal axis catheter with ARTS technique under balloon aspiration, balloon guiding catheter occlusion and aspiration. Here you see the solitary platinum. You get, here is the distal axis catheter. This is under balloon occlusion. We get all the distal axis catheter and stent together to the balloon guiding catheter. After 2 passes with combined technique and first aspiration, we get a good recanalization, and here is the material. Then this is actually after the pathology and TE examination, it's atrial myxoma material, an embolic material with axial myxoma. So there are other techniques. We can change the system. We have to we have to be familiar for all systems. We can use double solitaire mechanical thrombectomy technique or in parallel or with Y stenting type with the stent river. And I know Osama uses this technique. If we cannot achieve the recolonization after 3 passes or 4 passes, we can use it in certain patients for sure. There are new stents available actually. So these stents are embotrap. The rate of first pass thrombectomy for TICI 2B recolonization is 57%. And this is a RISE trial. Primary results. We need much more results to make comments for this stent. And this is NIVA stent. It's just recently approved, actually. And these are new technologies, but we have to see and wait for the results. And this is one of other patients, 60 years old male, 3 hours of symptom, aspect 9, NIH 20, previous MI. And this is the occlusion on the MCA. When we pass this stent and give the contrast, it's opened. But when we retrieve the stent, it's occluded. So we give the contrast from the guiding catheter, balloon guiding catheter, and see the severe stenosis. This is the Trevo stent here, and this is the stenosis, severe stenosis. So we thought that it's underlying atherosclerotic disease, and we inserted 2.522 coronary stent after clopidogrel loading. Here is balloon expandable stent under very gentle manipulation. And there are certain trials, certain actually intracranial stenting studies, and mostly coming from the east part. I know that in Egypt and South Korea, India have much more atherosclerotic disease, intracranial atherosclerotic disease. In Turkey, it's 5%, and we have most likely cardioembolic disease, 30 to 40%, and much more tandem occlusions, atherosclerotic carotid artery disease, and very less likely having intracranial atherosclerotic disease. So we have to actually combine our results. Actually, it may be very nice to combine our results and etiology. There is a very nice paper just came out in the World Neurosurgery. I'll finish my presentation with 2 or 3 slides. And you know, it's coming from Japanese group, and intracranial atherosclerotic disease is common there also. Actually, when you give a contrast after insertion of the stent river and giving contrast while the stent is opened, there are 3 patterns. One, you may have a very good expansion of stent, very nice expansion of the stent with a thrombus sign here, very nice expansion of the stent with a thrombus sign. And these patients may have more proportion of patients may have first pass thrombectomy. The stent is opened very well, and there is a thrombus sign, most likely thromboembolic. The chance of getting recolonization is higher. The second pattern is you get very poor expansion of the stent, and some thrombus sign it's heart clot. It's maybe heart clot from thromboembolic source and fibrin dominant. And the other one is poor expansion with no thrombus sign. It may predict actually the atherosclerotic disease. So when you have this, maybe you have to put a permanent stent. When you have this, you may change this pattern to not very good expansion with a thrombus sign. So you may change the system to the aspiration maybe. So these are all studies came out actually, and we can get some information from there, and we can change our strategies regarding to what we face. The fourth component of resistant thrombectomy is complication. If you have a near territorial infarction, like we see in this patient, the ACA is occluded, so you have to go for ACA also and try to open the ACA, anterior cerebral artery. during MCA manipulation. Or you have too much distal emboli, like this patient's tandem occlusion under balloon guiding catheter we use. Despite of the balloon guiding catheter, we had lots of distal emboli in these patients. And distal emboli, too much distal emboli may cause futile recanalization. You get some kind of recanalization, good recanalization without distal perfusion. So you may have futile recanalization. We can give intra-arterial thrombolysis to these patients, maybe. And these kind of complications may complicate the issue and may cause resistance thrombectomy. So these are last 3 slides for the recommendations. Balloon guiding catheter is recommended when you use an isolated stent. And stent can be performed with push and pluff or push to wire technique if the stents are radiopaque, like Solitaire or Trevo. We do, the studies are recommend 3 or 5 minutes wait for the stent after the stent replacement in order to engage the vessel better, especially for the nitonal stents, not for maybe embotrap, but for Solitaire, Trevo, Preset, Catch. Recanalization rate is higher in longer stents like 440 or 430. If you want to do the combined system, withdrawal of microcatheter is recommended when a combined distal access catheter and stent system is performed. Use of distal access system is recommended in tandem ICA occlusions. Combined distal access catheter system and stent system may be recommended in a very tortuous anatomy and very difficult anatomy. Intracranial stent should be kept in the neuroangiography suite for especially underlying intracranial atherosclerotic disease. After 3 passes, switching the endovascular system may be recommended. And be careful for the backflow for the adapt technique. If you do not have the backflow while aspirating the thrombus, it means that the thrombus is entrapped on top of the distal access catheter, and if you give a contrast from there, you can create a distal or ENT emboli to other territory. Intracranial permanent stenting is seldomly required, but we can get the decision regarding the situation. The decision of permanent stent insertion should be based on neuroimaging, age, symptom onset, and underlying etiology. So these are all my talk actually. To summarize, resistant thrombectomy may be caused by anatomical problems, may be caused by thrombus itself and technique, and may be caused by complications. So can you hear me,
Yes.
Osama?
Yes, we are hearing you very
So
much.
this is my actually presentation, and I'm very thankful to all colleagues and especially Osama to arrange this webinar. And this is the first webinar, but I'm absolutely sure that the next ones, it will be better and better. And by using this technology and by spreading this webinar series to our colleagues, we'll get great benefit.
Thank you so much.
Thanks, Osama. Other colleagues.
Thank you so much, Oskan. I think it's a very interesting topic and it's a very phenomenal lecture. Thank you for your presentation. And now we can have some questions about this topic, about 2 minutes or 3 minutes for any question. So if anyone have any question, he can raise his hand and I will open the mic and give his question for Dr. Oskan. Any question? So I have a question, Oskan.
For sure, Osama.
From your experience, do you have any signs or predictors to underlying intracranial atherosclerosis during making mechanical thrombectomy to be ready and prepared for such a situation? For example, in the CT angio or any pre-CAS procedure imaging, maybe it's very helpful to predict and to be prepared for such a situation.
Actually, you are much more experienced than us because we have very few cases of intracranial atherosclerotic disease in Turkey, 5%. But if you perform a CT angio and if you see the intracranial atherosclerosis, or calcified plaque on the presence of occlusion, or you can use prediction, or you looking at the other arteries, if it's intracranial atherosclerotic materials on the non-affected arteries, like the other MCA or basilar artery, it may give you some clue. The other thing is, during the procedure, actually, while you are opening the stent, giving the contrast from the guiding catheter, guiding sheet, or balloon guiding catheter, and see the underlying stenosis there. Sometimes it's very difficult to be sure about if it's underlying stenosis or it's thrombus. But if it's a highly stenotic segment, then it may give you a clue. Or if it's the occlusion is a little bit tapered and the stenosis is tapered, it may give you a clue that it may be an underlying atherosclerotic disease. These are my clues, actually. And what do you suggest, Osama, because you see much more atherosclerosis in Egypt than us?
I think you are right. This is a very important clues for expecting underlying intracranial atherosclerosis, and also before you can go and to be prepared for such intracranial atherosclerosis, you can examine the CT angio, and for example, you have indirect clues, like if you have a very high impact of calcification in the major arteries in the CT angio, it will be a clue for intracranial atherosclerosis. And also, if you have some discrepancy in the multiphasic CT regarding the collaterals, and if the patient have a very good collaterals in spite of having some very bad vascular risk factors, it will give you also another clue for underlying atherosclerosis. And as you said, also in the setting of very late arterial phase in CT angio, if you see tapering of the occlusion or acute cut off of the vessel due to the thrombus, it will be an indirect clue for underlying intracranial atherosclerosis. And from the history also, if the patient coming with peripheral vascular diseases or coronary artery diseases and have any stent deployed in such territories beyond the neurovascular system, it will be also an expecting factors for underlying intracranial atherosclerosis. Yes, it's similar. But I think it's very difficult. Even it's a game like a guess game, and you know, the subarachnoid hemorrhage, the density of the subarachnoid hemorrhage can be a platform for a play to guess where is the aneurysm before doing CT angio, and also it's similar to this aneurysm, guessing the location to have in the information before the angio or the cath lab procedure to expect the intracranial atherosclerosis. And the most important is to be prepared and to keep it in your mind as a possibility in each patient.
Okay. Very nice. We have to actually collaborate for the thrombectomy cases. Maybe find several clues in the future, because we have different etiologies according to the geographical and.
Can I ask a question?
Yes, please.
Thank you very much, Oscar. It's excellent talk.
Hi,
So I have I'm just gonna start the video here. I'm a little bit illiterate in this, but let me tell you something about acute thrombectomy in the presence of intracranial atherosclerotic disease. Our group here prefer to use what's called the infusions, like they use it in coronary artery disease. I'm blind on the name.
GB2A3B inhibitors.
Hello, Dr. Maher?
Yeah, I'm with you. You hear me?
Okay.
Yeah. So 2,3-B inhibitors. Yeah.
Yeah.
for better result of acute thrombectomy. What's your intake on this?
Yeah, actually, it's one of the unknown issues. Actually, it depends on the patient. I get individual-based decisions. If the patient is having a very bad aspect score is 5 or 6, not a very good aspect score. And if the patient is in older age, with leukaryotic patients with leukaryosis, severe leukaryosis, I do not tend to use this kind of strategies. But if in the younger age, good neuroimaging with an aspect score 8, 9, without any concomitant disease too much, the glucose is well controlled, I tend to use actually 2/3 dose of coronary literature. I give a 2.5 milligram of tropoban, and then followed by 8 hours of infusion. Whenever I perform a permanent stent, I just do the DynaCT or expert CT to see what's going on the brain, to see if there is a enhanced contrast, if there is an enhanced contrast extravasation or not, if there is any bleeding or not. If there is now, then I tend to give some tropoban infusions in this kind of patients. But I act actually for all patients for individually. I do not have any kind of strict algorithm. Sometimes if I see too much contrast enhancement in terms of Hans per unit, like 100 Hans per units of contrast in the basal ganglia region or other regions, then I reverse the heparin. I tend not to put intracranial stenting, permanent stenting. What I do is, if I have to put a stent, perform a stent, I do a DynaCT or expert CT, brain stat